Hello, my name is Dr. Ukiri Richard. I continue my podcast on basic cardiology today, and we are going to talk about focal neurological attack. The case we are going to use today is that of a 61-year-old female patient that came for you to clarify an attack she had that lasted for about 10 hours with hyperesthesia and dysesthesia, as well as paralysis of the right arm. The patient told you that she thinks the symptoms are actually caused by a clipped nerve, because on the day it happened, she really carried heavy load. In the history, you find out that the patient had an episode of dysarthria 2 years ago, and since then has been taking aspirin 100 milligram a day. The physical examination was normal, especially the symptom could not be provoked by any maneuver, and blood pressure were normal both sides, no focal neurological deficiency. The patient does sports regularly and feels well. There is no past medical history of note. The patient asks you now if she can be discharged immediately, because she only came to you for clarification because her daughter forced her to come. But actually, she does not have any symptoms. What will you answer her? An immediate discharge is not recommended, despite the fact that neurovascular or neuromuscular causes for the symptoms are possible. For example, thoracic outlet syndrome or focal nerve lesion. The symptom makes one to think of a transitory cerebral ischemia, so that a clarification of the causes, or check for a cardiovascular cause, especially here that you have a patient that is having a second neurological event, should be carried out. If the suspected diagnosis of a focal ischemia is verified, the incidence of a threatening stroke within the next 3 days is very high. So what test are you going to do for this patient? I will do a cranial computer tomography, which has a sensitivity of less than 25% for fresh cerebral infarction, or an MRI, which has a sensitivity of about 50% of fresh infarction, to clarify the localization and etiology, or also to check for subacute infarctions. You may need to repeat this test, because we know that this initial first day computer tomography and MRI sensitivity are very low, so it may need to be repeated after 2 or 3 days. So apart from the computer tomography or MRI, I will also do a 12-channel ECG and an ECG Holter to check for heart rhythm disturbances and arrhythmias like atrial fibrillation. I will do a 24-hour blood pressure check, Holter measurement, to check for hypertensive blood pressures. I will also do for a color Doppler, extra and intracerebral Doppler sonography to evaluate diseases of the cerebral vessels. I will do a transthoracic or transesophageal echocardiography to evaluate a recurrent, or to evaluate the risk of a recurrence of the cerebrovascular diseases. I will check for the heart valve diseases, aortic arc studies like plaques. I'll check for left ventricular aneurysms and PFO. I will also do a coagulation diagnostic, check for antithrombin, protein C and S inhibitor deficiency, APC resistance, factor V Leiden, and prothrombin mutation. Depending on the clinic, I might also need to do a vasculitis screening if the patient has night sweating, weight loss, adynamic joint complaints, and elevated acute phase protein like ESRO and CRP, leukocytopenia, thrombocytopenia, or anemia. You did the CT computer tomography of the brain, and you actually saw a fresh infarction in the left medial perfusion area. What measures are you going to carry next? I will transfer the patient immediately to the stroke unit, because according to the index of events, patients that have had this transitory ischemic attack have a 10% incidence of stroke in the first 2 days and 15% in the first 2 weeks. In transient focal ischemia less than 24 hours, I'm talking about TIA, patients with cerebral symptoms compared to those with retinal symptoms like amaurosis fugax, patients above 60 years with symptoms lasting more than 10 minutes, patients with paralysis or dysarthria are endangered. Okay, you transferred the patient to the stroke unit and you did a coxillary transthoracic echocardiography. Apart from a hypermobile atrial septum, there were no other abnormalities. Are you going to do other tests? As long as the above tests did not show any indication for the cause of the cerebral ischemia, don't forget that cryptogenic or idiopathic stroke have a 40% incidence for all embolic strokes. A duplex sonography of the legs veins, as far as a transesophageal echocardiography, to have an exact picture of the atrial septum should be carried out, so as to know the exact to know the probability of a crossed or paradox embolization, or to know and find out an intracardiac thrombus. During the administration of the echo contrast medium, a Valsalva maneuver can help to visualize the foramen ovale. Sensitivity is 90 to 100%. As screening method also, you still may need to do the transcranial Doppler with simultaneous application of a non-pulmonary accessible contrast medium. But here you don't have the possibility to judge intracardiac morphologies. Generally, the transcranial Doppler with the power motion mode as well as the transesophageal echocardiography have sensitivity of more than 90%. Compared to that, the transthoracic echocardiography has only 50 to 70% to identify a PFO. The duplex sonography of the leg veins could not show a thrombosis, but the transesophageal echocardiography was able to show a great atrial septum aneurysm as well as a PFO tunnel with flow of contrast medium across the septum. What recommendation are you going to give for in case of it as a recurrence prophylaxis? A recidive recurrent prophylaxis in this case can be taken from two therapy concepts: either conservative medicated therapy, or a catheter guided sham implantation, that is catheter guided closure. According to the German Society of Neurology, any patient with solitary PFO, irrespective of the size, with a single or the first cerebral ischemic event, will have a prophylaxis of aspirin. If under aspirin there is a recurrence, or if the PFO exists with an atrial septum aneurysm, then an oral anticoagulation with INRO 2 to 3 for at least 2 years is recommended. If it comes to another recurrence, or if there are contraindication for oral anticoagulation, then you can talk of the interventional PFO closure with catheter. The German Society of Cardiology hasn't given any written recommendation until now, but according to experts, an interventional closure can be carried out after a single cryptogenic cerebral ischemia, even when there's a solitary only a PFO without atrial septum aneurysm. The American Heart Association, American Stroke Association, and American College of Chest Physicians recommend presently an antithrombocytic monotherapy in patients with ischemic stroke and PFO, as long as there are no additional indication for anticoagulation. The data we have for a risk factor certification for a recurrent or another cryptogenic cerebral ischemia, like age, the combination of PFO and atrial septum aneurysm, that is when the septum excursion is more than 10, or a great PFO defect, are up to now not unified or not in unity. In this our case, just due to pure hypothesis, the cause of this emboli may be raised right atrial pressure when the patient lifted load. I think the indication for an occlusion has been met because there's a recurrence under aspirin therapy, and she also has an atrial septum aneurysm. Okay, a catheter guided atrial septum PFO closure was done. What do patients generally have to watch out or take care of after this PFO closure? To prevent a thrombus formation on the implantat, the combination of aspirin and clopidogrel should be taken for at least 6 months, because it should be taken or accepted that a complete endothelialization would have been completed thereafter. In the first 6 months, the patients also need to take endocarditis prophylaxis. Some centers recommend a controlled transesophageal echocardiography in 4 to 6 months after the closure. Thank you very much.